pulmonary vein. Or this is the segmental branches of
بالمونري امبوليزم يعني.
يعني it's okay. You must roll up and down to ensure it's a pulmonary vein or an artery.
Yes.
But in the whole, we are almost radiologists. How many cases you face a pulmonary venous embolism?
none.
فيش.
Common is common.
بس الشكل ده هو ده.
Yes. I'm
Yes.
recommendation for all: no diagnosis of pulmonary embolism by image on mobile. Because he's right. He maybe this is a pulmonary vein. Okay, we must roll an up and down. But I told you nothing tricky.
Yes, pulmonary embolism.
This is the segmental branches of the both pulmonary arteries. The CT pulmonary angio, as you see, shows segmental filling defects in lower lobe arteries. This is pulmonary embolism. My question is, what is the ancillary CT finding suggesting right ventricular or right heart strain? When you're facing a case of pulmonary embolism, you should, in your report, to say, is there is right ventricular strain or not? What is the signs suggesting right heart strain or right ventricular strain? This is, you should write in the report.
And this is a recommendation of the last ECR in this year. There was a consensus between the ECR and Thoracic Society, and so they told us we must put in the report the severity of the pulmonary embolism and the presence or absence of right ventricular strain. And so,
تفضل.
The caliber of pulmonary artery.
You mean the diameter of pulmonary artery? Again, also? Another. You said the diameter of pulmonary artery.
to make it more easy, we have four findings. 2 is major and 2 are minor.
Yes.
We have an answer here.
What about the chambers?
Okay.
Yes.
السبتم بيبقى deviated to the left.
Yes, this is one.
Minor ولا major?
لا الميجور.
Minor.
The chambers. What about the chambers?
Dilate right atrium and right ventricle.
Right ventricular enlargement.
Enlargement.
And right atrial enlargement.
Yes.
And the bowing of the septum to the left side. And the diameter of the pulmonary artery is enlarged. Others?
The 2 measures are dilated main pulmonary artery and right ventricular enlargement. Bowing of the interventricular system may be a minor, and the last minor.
I'm not sure, but superior vena cava may be dilated.
It's a little bit near.
Hepatic veins. What about hepatic veins and IVC?
Yes.
IVC and hepatic vein dilatation.
Yes.
Dilatation and what's called contrast reflux.
Yes.
But this depends on the accurate timing of the technique. Okay? That's why it's minor, because it depends on the technique.
Yes. Again, the dilated pulmonary artery, enlarged right ventricle, bowing of the interventricular septum to the left side, reflux of the contrast within the hepatic veins. This is the ancillary finding to say right ventricular strain.
Also, we can see signs of tricuspid reflux, tricuspid regurgitation. Yes. That's why if we do early phase of the upper abdomen, we can see early opacification of the inferior vena cava.
Yes, this is what is called contrast reflux.
Yes, reflux of contrast within the hepatic veins and IVC. Yes, yes.
Thank you. Twenty-five-years old male with history of severe COVID-19 infection and ICU admission. 1 week after improvement, he presented with severe dyspnea, and this was the CT chest, mediastinal and lung window.
large right lung mass with bronchial tree attenuation يعني suspected mass.
Suspected mass.
Yes.
Malignancy, bronchogenic.
Yes.
In 25 years old, it will be your first possibility. 25 سنة. What is the youngest bronchogenic carcinoma you diagnosed? هنا دكتور خالد يتحدث. Yes. Very rare. Yeah.
يعني طبعا it's definitely a disease of the elderly. We had a case in Ain Shams, 14 years old, but it was a genetic, he had a mutation. Definitely this is not an environmental factor. But and again, if this patient didn't have COVID-19, I would have suspected something like lymphoma, by the way.
Okay, we have two differential diagnoses now. Lymphoma, okay, especially with the history of COVID-19. And of course, we almost would put the bronchogenic carcinoma in diagnosis, whatever the age. But the priority of your differential diagnosis, and this is an important factor in your reports, you must organize your differential diagnosis by the most accurate from your point of view and to the least. Regarding 25, almost we can put bronchogenic carcinoma as a remote possibility, a lesser extent. Lymphoma, of course, with the history. Another issue.
I see area of consolidation with air bronchogram.
Yes.
He is immunocompromised due to COVID,
Yes.
so it could be super added bacterial infection.
Or
fungal.
Fungal infection. Fungal infection is the one of the infection can be presented radiologically by masses. Okay? And so, this is the same patient.
Yes.
Yes. And so, your orders of differential diagnosis will be first, fungal infection. Second, lymphoma, of course. It can be also infiltrating the sinuses and show intracranial extension. I think bronchogenic will be remote and remote because it's an metastasized intraaxial, not a sinus with intraorbital extension. So this will be a very remote possibility. This is a culture. It was a fungal infection, the type what's called airway invasive pulmonary aspergillosis, which is presented by a consolidations and forming mass-like lesions.
Another patient, 35-year-old male with fever and cough. What you see? Yes. Why you said abscess? What? Why you said? Yes.
Right lung في لبسة right lung
Yes.
في abscess.
What you see in the radiological appearance? Rounded cavity with air fluid level.
Air fluid level.
Yes.
Fluid. في fluid.
Air fluid level. Yes. With yes. Chest X-ray, as we said, showing cavitating consolidation in the right upper lobe with thick-walled cavity showing air fluid level. The diagnosis is lung abscess. My question is, how you differentiate between lung abscess from emphysema? How you differentiate between lung abscess from emphysema? Do you know what emphysema? Plural, yes. How you differentiate between lung abscess and emphysema?
اللنج ابسس متحوطه باللنج من جميع الجهات اكتر.
Yes.
انما الامبايما بتبقى بلورال بيست.
This is the only differentiating point.
انسيستي ديفيوجن جواه اير فلويد ليفل بيبقى امبايما.
Any other? Yes.
also the shape.
Yes, very good.
empyema
The
is
shape.
elliptical.
Oblong.
Oblong shape.
Or biconvex.
And
Yes.
take the shape of the pleura,
Ah,
but and the peripheral.
yes.
But abscess usually central and rounded.
Rounded with,
With airflow.
you know about the split sign? This is
It's also
Pleura split
empyema
sign?
Splits
the visceral from parietal pleura, yes. This is the main differentiating point between the abscess and empyema.
My question in the same case, how we can differentiate abscess from a cavitary lung mass?
Yes.
Yes. Wall. There is a cutoff value.
Regular border.
What?
The inner lining of the wall is irregular.
Irregular. Second sign. Wall thickening and the irregularity of the inner wall. Some papers, okay, take 15 millimeters as a cutoff value. Okay. Another case, rapidly. 14 years old female complaining of dry mouth and now complaining of dyspnea.
Case of lymphangioliomyomatosis.
Why?
Because there is cysts, variable sized, female. The cysts are more or less uniform size and scattered bibasilar predilection for the lung basis.
Okay, and the lung in between?
What?
The lung in between?
I didn't hear well.
The lung in between the cysts?
The lung in between cysts, yes, appear clear. Hey.
This is a clear lung?
Area of ground glassing, but not so much ground glassing. I mean, the predominant feature is the lung cysts, clear lung cysts.
Yes. So we are dealing with a case of pulmonary cysts. Okay? The female, okay, make the differential diagnosis is LAM, lymphangiomyomatosis, or
Langerhans.
lymphocytic interstitial pneumonia. Both are female predominance. Okay? A little bit, the lung parenchyma is a little bit ground glassing, not a completely normal. Okay? This may put the LIB, my first differential diagnosis, then the LAM. Especially with the history, dry mouth is indicating of what? Maybe underline Sjogren, yes, Sjogren syndrome, and this is a very strong association between Sjogren syndrome and LIB. Rapidly, for the time.
The last case is 50-year-old male smoker with weight loss. What we see? Smoker with weight loss. Yes, yes. What?
في posterior speculated mass.
Yes.
وفي pulmonary embolism كمان.
Pulmonary embolism?
في filling defect اهو.
You said the speculated mass lesion, yes?
تحت ايوه.
Pulmonary embolism?
ايوه في pulmonary artery الليفت برانش في سوري رايت برانش قدام ماس بالظبط في filling defect جوه البلمونري artery.
وايت ارو ها؟
ايوه الوايت ارو دي مش embolism.
The yellow arrows.
لا اليلو اروز والوايت ارو الاثنين حساهم جوه البرونكا جوه الرايت برانش اوف بالمونري ارتري.
The yellow arrow.
تمام اليلو ارو في الروت ايوه بتاع الرايت برانش.
Yes.
اوكي والبوستيريور سبيكوليتد ماس اي ثينك ان دي يعني مالجنانت ماس.
For the time we have central hilar mass speculated as you said associated with mediastinal
تمام
lymph nodes.
تمام
Mediastinal lymph nodes.
تمام اوكي.
Yes, and CT shows central mass causing bronchial obstruction and hilar lymphadenopathy, hilar and mediastinal lymphadenopathy. The diagnosis is squamous cell carcinoma of the lung. My questions is, what is the typical radiological difference between squamous type bronchogenic carcinoma and adenocarcinoma. How you differentiate? Radiological. Squamous and adenocarcinoma. Site, very good.
السايت السكويمس غالبا بتبقى سنترال.
Central, yes.
الادينوكارسينوما اللي هي البرونكو الفير كارسينوما.
Yes. بتبقى.
بريفرال وتيجي ممكن تيجي بكونسوليديشن.
Yes. What about the lymph nodes? What about others? What about cavitation?
Cavitation?
Yes.
Cavitation في الادينوكارسينوما.
Cavitation is with adenocarcinoma?
Squamous.
Cavitation suggesting squamous. Adenocarcinoma is peripheral, associated with some sort of atelectasis and consolidation like that. Again, as we said first, regarding lymph node, calcified lymph node suggesting TB or carcinoma.
TB.
Yes. Is it possible to see calcified lymph node with carcinoma?
Treated lymphoma.
Is it possible?
ممكن في
Where? Eccentric? The mass of the bronchogenic carcinoma. Is it possible to see calcification within the mass? Could be.
Could be.
الانكولوجيست معانا دكتور خالد.
لا هو انا كنت هكومنت على حاجه صغيره ان اتس your comment on the suspicion of the type of histology is important.
Yes.
لان ساعات البيوبسي مش بتبقى conclusive لاسباب
Yes.
كتيره crushed ومش عارفين نعمل اميون كيس but it's important also to recognize and these rules are not 100%.
Yes.
يعني عندنا adenocarcinomas بيبقوا central ساعات
Yes.
squamous ف your opinion to suggest that this is in favor of
Squamous or
potentially
adeno?
squamous or
Yes.
potentially adeno is relevant to us لما بنبقى ساعات في gray zones بسبب الباثولوجي بس yet we need all to be very humble while recognizing there is no 100% agreement that it always the case.
Yes. Yes. Yes.
Regarding staging,
Yes.
we have a mass which is suspicious
Yes.
for being cancerous. Can we add a conclusion with TNM staging before having a biopsy?
Yes. Regarding the size, as you know, less than 3 centimeter is TNM1. Between 3 and 5, 2. Between 5 and 7, 3. More than 7 is T4.
يعني معلش I'm sorry to
Yes.
comment again.
Yes.
Very important to tell us on which TNM classification ال AGCC staging بيتغير كل شوية.
Yes.
فعندنا ال7th ال8th وال9th لسه طالع أو هيطلع.
applied already خلاص.
فايتس important حضرتك تقول لي أنت عامل classification بأنهي واحد.
Yes. Yes.
دكتورة داليا معلش سؤال سريع. It's very important to enumerate the longitudinal cases of lung cancer. To what extent it's very important. Can we see a pulmonary nodule in a bronchogenic case and ignore and even not reporting, even it is very small and even you are sure it's benign?
اللانج نوديول بالنسبه لنا يعني مهمه جدا في الدايجنوز بيشنت حتى لو العيان دايجنوزد ان هو اتس كيس اوف نون سمول سيل لانج كانسر. اللانج نوديول وجودها بيفرق معانا جدا في الستaging يعني very simply كده. If you have another lung nodule in the same lobe, it already classify my patient as a T3. Another lung nodule in the same side, different lobe, it classify my patient as a T4. A contralateral, if it's single, احنا بنفضل بقى في dilemma. Is it a metastatic M1 disease? Or are we talking about two synchronous different primaries of lung nodule? Is it very common scenario? No, it's not. بس دي one زي ما دكتور أحمد عارف one of our dilemma. لو العيان عنده contralateral multiple lung nodules خلاص الدنيا بتبقى little bit محسومة بالنسبة لي it's mostly metastatic but the presence of a contralateral single lung nodule دي بتزنقنا دايما في الام دي تي زي ما دكتور أحمد عارف. So
and thanks for Dr. Daria and this is a very important of the MTT. Okay, we couldn't judge on the case without the oncologist in your back bone and the oncologist, chest clinician, and even the thoracic surgery. To what extent it's very important to take a decision in such a nodule. Especially we don't have a guidelines to judge on the pulmonary nodules in a known case of bronchogenic or even any cancer elsewhere. We have a Fleischner, we have a British Thoracic Society, we have a lung grads, but all make a condition for you. You don't allow to use these guidelines in a patient known to have a cancer. So the MTD is very important because it's a little bit بيريحنا. يعني أحيانا كتير قوي يقول لك خلاص he is accepting as an oncologist to wait and see. It will not make a big difference. So all of us know the most important parameter to judge on a pulmonary nodule is a follow-up. Not even the PET CT, because even the size, if less than 10 or 8 to 10, the accuracy of PET CT is a little bit questionable. So it's a lot of times, even the thoracic surgeon tell you, for the benefit of the patient, we will consider the nodule is non-specific to just catch the patient with the surgical stage, and we will do the operation, especially if the nodule is very small and a little bit not suspicious for you.
Thank you. So I have a question here. We see it a lot. We have like either bronchogenic or
cancer breast,
primary, or even unknown.
Yes.
I see like some nodule, and they are asking me, is it a special nodule? Is it metastatic, or is it just inflammatory? So do we have like some tips and the tricks other than follow-up to differentiate between these two? And is there a cut-off size to further go for PET, or?
8 to 10 is the cutoff value for PET CT. The accuracy increase with more and more increasing the size for regarding the PET CT. Still, the most important is follow-up. Unless it's very obvious from the start, large, speculated, okay, newly developed, especially if the patient is on follow-up, okay, this is hazard fuzzer.
See, my personal experience, when I see them like parenchymal, well-defined, I see like they are suspicious. If we have like some irregularity, fibrosis around, they are like inflammatory, but I don't know is it the rule or not.
We finished. This is the last case I don't answer. There is a very strong association between other organs and the lungs. If we have a case in ICU with subarachnoid hemorrhage, you must think if the patient deteriorated and deoxygenated and go to the ICU, you must don't forget the ARDS or non-cardiogenic pulmonary edema cases. Thank you. Again, it's very important, MTD. Please try to make an MTD in your department. Thanks a lot, and sorry for the long